ED patient with abdominal pain, something nonsense. This was the key kind of image where the abnormality was found. Anybody has any thoughts?
Yeah, the pancreas looks a little sausagey, especially the tail.
Right, so that was, picked up. You can see that the tail is very, it kind of lost that nice little feature feathery appearance, as you can see here. It's very subtle. So the patient had a follow-up MRI about a month after, 2 weeks after.
Victoria, is that your phone?
Until right now. Sorry, we're in a reading room. But so you can see that now the appearance is very striking, right? So on the pre-contrast T1, weighted sequences, which is a great way to look at the pancreas, you can see very sharply demarcated abnormal signal intensity in the tail. There's also another area here in the head. And then you can see kind of this rim-like area of hypo-enhancement. Patient kind of pooped out at the end. And, it has a pretty, you can see that there's slight kind of intermediate and, kind of almost edematous appearance, right? And you can see that the pancreatic duct, here it is normal in the head and neck. And then it just kind of disappears here, maybe a little bit here. It's actually narrowed instead of been dilated. And the other area looks in exactly the same way. This is a very classic appearance. Residents? Anybody? Rob? Right, so this is an autoimmune pancreatitis. You can see it's restrict. So this is a very classic appearance of autoimmune pancreatitis. So it's diffuse in about 40 to 60% of the patients. On CT, again, we see this featureless appearance with effacement of contour. On the MR, the affected areas are low on T1 and slightly higher on T2. And then enhancement may be heterogeneous and decreased. And then this capsule-like rim enhancement is due to inflammatory infiltration. You can see in up to 40% of the patients. And this patient is very classically appearing. And then sometimes it can be very segmental, and it can mimic neoplasm.
Isn't there like a abnormal blood marker associated with it?
This is one of the few years ago it's been linked to other IgG4 related diseases. In many cases, autoimmune pancreatitis is standalone manifestation, but it can be associated with other, including IgG4 nephropathy, and we had a case of biliopathy with autoimmune pancreatitis, and these respond very nicely to what do you call it? To
steroids.
The steroids. Sorry.
There's two types, right? There's like type 1 and type 2 autoimmune pancreatitis?
That I am not sure. Anybody?
Yeah, so I can't remember which one is which, but I think type 1 is the one that's only affecting the pancreas. Does anyone know? Anyway, one of them only affects the pancreas. The other one is the systemic type. So that systemic type is going to be multi-organ, and those are going to be the ones that have the serum elevation in IgG4, and I think that's about 40% of them. So if you get that, you have to look at like multiple organs, and then if you get that serum IgG4, that's really helpful. But otherwise, if it's only affecting the pancreas, that's the other type. And that's much harder to get the diagnosis because you basically have to get like big cores of the pancreas to get that diagnosis. And there's all these like pathologic criteria. But usually if we suspect it strongly, they'll give them a steroid trial. And then if that responds, then they kind of have the presumptive diagnosis. Type 1 is multi-organ. Okay.